understand you guys got copies of them. There's a little anatomy. All right, that's kind of giving you a look at, you can kind of get an idea of the anatomy of the cervix into cervix. Your transformation zone is tends to be, does it show that? Where you can see the external os, that's where your transformation zone, especially in young girls, it tends to be on almost the vaginal portion of the cervix. As you age, it does migrate back up endocervically. That's just a histologic picture of ecto and endocervix. Again, these slides, I'm not a pathologist, so I'm not going to go into the blood supply. I don't think that's important at this level. HPV infection or risk, we talked about that. Multiple sexual partners, early age of sexual activity, high parity, especially if they had their first baby was before the age of 20. Well, that kind of goes along with what we were talking about, early onset sexual activity. Obviously, immunosuppression, we all understand why that would be problematic. In fact, some people will tell you if you diagnose a cervix cancer, you should consider checking an HIV. And cigarette smoking, they've done studies and looked at how quickly some of these byproducts of smoking appear in the cervical mucus, and it's amazingly quick. It's within minutes. And so they can, those carcinogens can interact with the HPV and increase can increase the risk that it's going to lead to further complication, as well as cigarette smoking does suppress your immune system somewhat. Failure to participate in the screening program. That's where our problems in this country are. We got a significant portion of the population that doesn't get screened, which is unfortunate because, again, cervix cancer should be a thing of the past in this country. As I told you, most patients clear their HPV infections, but for those who don't, that's a risk factor for developing a cervix cancer. And 16 and 18 are most virulent types. That's just a picture. That's not quite called dysplasia yet. It's just showing some changes on these cells on path. They call it colposcopy, but it's at that point they're not calling it dysplasia yet. We talked about the advent of the pap smear, which had a profound impact on the incidence of cervical cancer and morbidity, mortality in this country. Now we've also got the Hpv testing, and we also have come up with a vaccination now as well. That's a picture of, on the left there, it looks like a low-grade dysplasia, on the right a high-grade dysplasia. So when you get an abnormal pap smear, we bring you back in, we do what's called a colposcopy. So as you can see, it looks like this guy's got a pair of binoculars there, and he's able to magnify that cervical epithelium. And we look for several things when we do colposcopy. We're looking for things like what they call mosaicism, neovascularity. Really, one of the things we're trying to see when we do a colpo is we're trying to see that transformation zone. And if I can see, because a lot of times we have dysplasia clinic and we get patients in with dysplasia, and let's say we're told she's got CIN1, what's our job? Our job is to examine her to try to determine if if that's the worst of her problem, or is it worse? Does she have a worse lesion? And so how we do it, we do a colposcopy. We want to see that transformation zone. And if I can see that transformation zone, 360, I'm pretty comfortable that what I see is what's there. But if I can, and I label that adequate colposcopy, if I cannot see that transformation zone, because sometimes it migrates up there and gets up high into the endocervical canal, that would be an inadequate colposcopy, and that's where we wind up going to leaps and cones, trying to prove that there's not a worse lesion, because you don't want to miss a cervix cancer. It's not good. Dying of cervix cancer is not a way you want to go. Yes?
I had a question back on the PAP slide. It says that it's the screening for cervical cancer, but then it says it's not a screening for cancer.
What's that?
On the PAP smear slide, it's like 2 back.
It's not a screen, in reality, it's not a screening tool for cervix cancer. However, we find cervix cancers when we PAP. It's more designed to find, subclinical disease. We're going to find dysplasias and precancerous lesions, what's designed to find. So now I know I got something I need to watch or I need to interrupt. Sometimes my PAP's going to come back going, cancer cells present. Oh, well, okay. Then we're still going to bring that lady into a colpo and biopsy her. It's not designed to find cancers. We hope we're going to find it before it gets to that level. Okay, does that make sense?
Yes, that's exactly what I meant. Thank you.
Okay, it looks like that's a pre-malignant condition, and as you can, that picture doesn't really do it justice, but like the bottom of it, you can see that white stuff. And we could really magnify that. You would see like cobblestoning or a mosaic pattern with the neovascularity. That's apparently a precancerous lesion. That's another showing you what the PAP stuff that looks like when your pathologist is reading these. And as you can see, we talked about CIN3, severe dysplasia, carcinoma in situ. I think the better terminology from my point of view is severe dysplasia or CIN3. I think it's more descriptive. When you start calling it carcinoma in situ, I think that is confusing to some people, but it's not going to be confusing to you guys because we've now discussed it. Carcinoma in situ is still a pre-invasive lesion. Not for long, it's full thickness, it's abutting against that basement membrane, but it isn't penetrating. Therefore, it is not a cancer. In order to be a cancer, it has to penetrate, all right, it has to invade. Well, they're talking about management. Well, that's a good point. As I told you, when we were PAPing, we used to think that we should PAP. If you're sexually active, 13, 14, 15, you need to be getting PAPs, which led to a lot of unnecessary procedures and probably causing some morbidity. So we just, the societies have decided that's probably not what we should be doing. And so that's why we've gone to PAPing at age 21. So yeah, you want to look at, because younger women are much more likely to clear their dysplasias. So yeah, age and desire for pregnancy, likelihood of compliance. If you think this patient's going to disappear, then that might go ahead and push you to get a little more aggressive in your management. Do they smoke? Are they immunocompromised? Shoot.
Is it provider preference to move from a abnormal pap right to a colposcopy instead of redoing the pap smear to see if both are abnormal? Because I've heard of both. Like if you get one abnormal, redoing the pap, or just immediately moving to
Yeah,
colposcopy.
you know, I've seen people repeat it. I'm biased. I think that if that's not what you deal with and you get an abnormal pap, I'd be sending the patient on to somebody that manages these types of things. I don't know how much the primary care, how many times they're going to do a colposcopy. That takes some specialized training. Yeah, if you got back, for instance, ascus, atypical squamous cells of undetermined significance, yeah, you might want to bring that lady back in and pap her again. Now, if she's an older lady, you might want to just go on to a colposcopy. Okay? I don't know that I'm necessarily the best person to ask that question. There's a cervix, that's kind of an exophytic lesion. There also looks a little ulcerative, doesn't it? All right, incidence mortality have decreased over, okay. You can take that for what it's worth. There's a distribution of cervix cancers now. As you can see, Africa's still got quite the problem. The U.S. is actually, we used to have a little darker color. We're actually doing better now. Well, that shows you the natural history. Cervix cancer, primary prevention would be the vaccination. But if you don't get the vaccination, you get infected and develop a precancerous lesion potentially, or it regresses and we never know you had it. Okay. Prevention. We talked about the importance of trying to improve our immunization rates and getting patients in a good screening. Even if you've been immunized, you still need to participate in the screening program. There's somebody collecting a pap. That's an endocervical brush that they're using there to get some of the endocervical component. There's a huge cervix cancer. That's a radical hysterectomy specimen. And what you're seeing is that's the uterus, but now they've got, remember I told you they take a centimeter of vagina, that's what he or she is spreading out, and that big thing in the middle is the cancer. So squamous cells are 80%. So squamous cell carcinoma is the most common type of cervix cancer. And then the rest of them tend to be adenosquamous. And then we've got some off-liers, not like neuroendocrine or small cell. I hate it when we would get a small cell because it meant that person was probably terminal. Despite, even if it's early, they just metastasize so early. Pretty depressing. These tend to metastasize with direct extension or direct invasion to adjacent structures and then lymphatically. And as you can see how those ureters come down, and you see those nodes right there by the ureters. Those get diseased. They can get huge. They'll cut off that ureter or obstruct it, and that's usually not a good sign. In fact, if we get a patient with flank pain, hydronephrosis, and pain shooting down her leg, that's a triad that is not a good prognostic sign. Okay, and of course prognosis depends on the staging. Typically, to stage these patients, we'll, once we know there's a cervix cancer, we typically get a PET scan. Are you guys familiar with PET scans? PET scans are basically taking advantage of tagged glucose. We know that malignant tissue is hypermetabolic and it tends to take that glucose up much quicker than normal tissue, and on a PET scan it should light up abnormal areas, and so that's part of the staging. We typically, a lot of times we'll take them to the OR and do an exam under anesthesia with a cysto or procto to look for not only when the patient's relaxed, you can feel that tumor a lot better, and you can also do the cystoscopy to look for bladder involvement and proctoscopy to look for rectal involvement. Looks like that's another radical hysterectomy specimen. As you can see, the uterus and ovaries on the top. At the bottom, they've got the retractors on that vaginal cuff that I talked about, and that big glob at the end there is the cervix cancer. And with that size of tumor, I would almost bet money this lady had positive nodes. Remember I talked about external beam radiation, which you can, they're using some kind of a, on the left bottom, machine to shoot a beam. The top right, that is like what we call a tandem ovoid or tandem ring. That rod goes up into the uterus, and then these rings butt up against the cervix. Those are loaded with cesium or some other low-emitting source. These ladies are flat on their back for 72 hours. They can't get up, or that thing slips out of position, so you have to suppress their bowel function. You got to put a catheter in. We had to do that on 2 different occasions. Now we have something called high-dose brachytherapy. And that entails we got to suture in a little plastic, it looks like a little plastic disc, and it's actually sutured in right at the cervix, and now they can go downstairs, get hooked up to a machine within minutes. Took us days to do, but that's going to depend on the anatomy and whether or not, because you got a big bulky tumor, you may not be able to use a cervical sleeve, and you still may have to go with the low-dose brachytherapy. But again, as I said, most of my medical students, when I ask them what brachytherapy is, they don't have a clue. I was a PA for 2 years in GYN oncology before I figured out what they were talking about. So never hesitate to ask questions. Don't walk around ignorant like I did for 2 years. Oh, the other thing they're looking at is that is cisplatin. That's the primary drug we use for the radiation sensitizing. Again, it's a low dose, so the patients don't usually have a lot of side effects from that, don't usually have a lot of hair loss. Not that you can't have hair loss from cisplatin, but we're using such a low dose because I'm not trying to get a cell kill from that cisplatin. I'm trying to just make those tissues really sensitive to the effects of radiation. Let's just go through this. Here she's showing you a polyp, benign lesion in the cervix. It's typically benign. All right, now we're going to uterine. Okay, what are we looking at there? Endometriosis is what you're looking at there. Again, you guys all knew that is ectopic endometrium, where it's not supposed to be, and it's very hormonally reactive, and so a lot of times, like an endometrioma is a endometrial tissue that's gotten on the ovary, and now it's responding to the effects of the estrogen and progesterone. And so a lot of times we'll get these big lesions called endometrioma or a chocolate cyst. It's because those things they bleed, and all this old blood, it just looks like chocolate. There they're showing you a couple of sites of the endometriosis. And endometriosis can be really problematic for, I've seen some ladies coming in with endometriosis. I mean, it just causes a lot of adhesions, a lot of pain, painful intercourse. It can be very debilitating in some of these patients. And it can be a nightmare to operate on some of these people. Here they're talking about that endometrioma. That's an ultrasound of an adnexal mass or an ovarian mass in the area of the ovary. Some more implants can lead to dysmenorrhea, dyspareunia, infertility. You guys can read that as good as I can. Treatment of endometriosis, well, it can be very conservative all the way to trying to do a surgery, which frankly we try to avoid because we don't seem to have a lot of great outcomes with trying to manage these surgically. Adenomyosis is endometrial glands are actually within the myometrium, the muscular structure of the uterus. It can a lot of times be asymptomatic, but it can cause some discomfort. So diagnosis, histology, MRI, you can treat it hormonally or you can do a hysterectomy. That's just another polyp. That's an ultrasound showing you endometrial polyps. You might see that on a lady. Remember we talked about tamoxifen and how that can lead to endometrial cancer. You do an ultrasound on a lady with tamoxifen, you see all those polyps. She's headed for a DNC. We talked about fibroids. They're benign, but they can get gigantic. They can get huge. It's just amazing how huge they can get. A lot of times you can treat those with suppressive agents, or you can take them with surgery. They talk about the different descriptions of intramural, submucosal, subserosal, intracavitary, pedunculated, big old lesion on the top. It's tethered. And sometimes those things can torse and cause a lot of pain, and they're going to wind up going to surgery pretty quickly. There you go, look how big that thing is. I mean, what's what? You can't even tell. You guys can break that as well as I can. All right, endometrial hyperplasia. Increased proliferation of endometrial glands. It's the precursor to carcinoma. You'll see it in pre- and postmenopausal bleeding. Can be, as we talked about, related to anovulation, and typically is heralded by some type of abnormal bleeding. That's going to show you. We talked about measuring your endometrium, and that's what they're showing you there. Is they're trying to measure that endometrial stripe. Can everybody see that? I don't know if we get this pointer. That's what they're trying to do to demonstrate to you right here. Endometrial stripe right there. Ideally, we want that less than 5 millimeters, especially postmenopausal ladies. We talked about prolonged estrogen, polycystic ovary syndrome, what role that can play, because now I'm not making corpus luteum to try to change that from a proliferative to a secretory endometrium. Obesity, talked about what role that plays, peripheral conversions of androgens and estrogens. We used to see exogenous estrogen. I don't really see that anymore. You will see people on tamoxifen. And then a granulosa cell tumor of the ovary, which are pretty dang rare. I think my whole 30-year career I've seen 3 or 4 of those. But they can be estrogen producing. As I talked about, AGUS on cytology, atypical glandular cells or distinct glandular cells in a postmenopausal female is worrisome. They shouldn't be having them, okay? So that's gonna lead you to evaluation. And you can see endometrial cancers and hereditary non-polyposis or Lynch 2 syndrome. There you go, there is a hereditary component to that. Remember I talked about the pipette, the endometrial biopsy? That's what it looks like, a little plastic straw, and it's slipped up in through the cervical canal, up into the corpus. And you can see there's a little thing with the red arrow. That pulls back, that creates a vacuum. And then you just kind of work that thing back and forth, trying to get a good sampling of all that tissue up in the, and you do that all the way out, because you want to try to get a good sampling of all the endometrial cavity. It was thought that that might not be as good as DNCs, because of DNC you can certainly get a lot of tissue. And experience has shown that it's pretty effective, and it probably doesn't require DNCs. So that's how we do it in the office there. That talks about the different levels of hyperplasia, simple hyperplasia, complex hyperplasia, and then hyperplasias with atypia. The atypia is the key. There's atypia, then there's we're worried about there might be an occult cancer. We just haven't proven it yet. Prevention. Well, oral contraceptives or IUD that is impregnated with a progestational agent. You can put a patient on that has simple hyperplasia. I can put a patient on a progestational agent 10 days a month. Withdraw it. Make them cycle. Make them have withdrawal bleed. Or you can put patients on, long-acting medroxyprogesterone. And you might see some providers doing that with patients who come in obese. I've seen Dr. Walker prophylactically use Mirena IUDs for some of these morbidly obese patients. And you know what, guys, we talked a great deal about postmenopausal bleeding, and most of these patients are older that have endometrial cancer, but don't get fooled, they don't have to be. I've seen a 19-year-old who's morbidly obese, already has endometrial cancer, so you still have to do your due diligence even if they're younger, but most of the time these patients are going to be older. So here they're talking about type 1 and type 2, and as you can see, type 1s are estrogen dependent, type 2s are not. Our precursor lesion type 1 is endometrial hyperplasia. Type 2, they tend to don't really have a precursor lesion. The earliest finding would be endometrial intraepithelial carcinoma. Another thing I didn't mention, you guys are going to start eventually seeing this, is the new terminology for complex atypical endometrial hyperplasia is EIN, endometrial intraepithelial neoplasia. Now you notice I didn't say endoepithelial carcinoma, I said neoplasia. So complex atypical endometrial hyperplasia, you might see it called EIN. Type 1s, I've had ladies out there bleeding for 2 years that come to see us. She's got a bad heart, so I got to send her for a cardiac workup. She winds up having to have surgery on her heart. 6-8 months later, we get her to do surgery finally, and she still does fine. So these type 1s in many cases are somewhat indolent. Give them long enough though, they're going to kill you. And they tend to spread lymphatically. Type 2s are more aggressive. They will intraoperative and lymphatic, intraperitoneal and lymphatic spread. As you can see, endometrioid tends to be well differentiated. Type 1, type 2s are other histologies of more concern. That's just showing you the lymph node distribution again. So they're surgically staged, and then based on the risk factors that we find, for instance, we look at several things. We're going to look at what was the grade of the tumor. Is it grade 1? I like grade 1s. Is it grade 2 or above? Well, that's a little bit worrisome. How deeply does it invade the myometrium? Is it less than 50%? I like that. If it's more than 50%, that is a risk factor. We look for what we call LVSI, or lymphovascular space involvement. If it's absent, great. If it's present, that's a risk factor. So based on all those things, we usually get together once a week in a tumor board conference, and we'll come up with a consensus recommendation as to whether these patients need adjuvant therapy. Does everybody understand the difference between adjuvant and neoadjuvant? Here's the way I keep it straight. Adjuvant, I'm adding treatment to something I've done. Neoadjuvant means, whoa, we're going to that treatment up front. Okay? And there's and we'll talk a little bit about neoadjuvant treatment with ovary. So adjuvant meaning, do I need to do more therapy, i.e. some radiation or some chemo? And then again, that's based on all those different things that we just talked about. You know, leiomyosarcoma, I'm not going to go into this. Leiomyosarcoma is a smooth muscle. We talked about, when we first started, carcinomas have to be epithelium. Sarcomas tend to be muscle, bone, adipose tissue, vascular tissue. I can have elements of both. I can have an adenosarcoma, but we don't see a lot of leiomyosarcomas. That's it on that one. I think we're ready to go to the ovary. Questions?